This
Can you hear me?
conference will now be recorded.
Yes, sir.
Hello. How are you all?
Yes, sir.
How are the spirits going on? So I think it is 9:16 now. Only how many are here? Only 99 are there. We'll continue and start. Shall we start now? Just before I start,
Yes, sir.
message. Those people actually I have found affection to the latecomers in the class also. Today also, those people who join late, be ready for the questions. Okay. So I'll give preference to those people who will come late from now onwards. And after half an hour, I'm stopping them. I'm locking the meeting. So maximum I'll give 30 minutes time because I know you are all busy people. So I'm starting now. Today, the topic, as I told you last time, is the diabetic ketoacidosis. If you remember, in the previous class, we were talking about the diabetes, isn't it? So while doing that, I just have shown you this particular slide. Special consideration under type 1 diabetes mellitus. See, we have discussed about honeymoon phase, Omag, dawn phenomena, management of sick day management, and all these things. And the last one I left off without even discussion is the diabetic ketoacidosis. So today we'll exclusively reserve that particular to the diabetic ketoacidosis. As I told you, this diabetic ketoacidosis is a special consideration you must keep in mind in all those cases where a child is presented with acute abdomen, as if it is appendicitis. So before you think of any surgical, the medical emergency that you should not miss is one is a diabetic ketoacidosis. It presents just like pain abdomen, nothing else. Or encephalopathy, sudden onset of a altered sensorium, that is posturing and various cranial nerve abnormalities and all this, rise in intention evidence is like that. And whenever a child comes with a severe dehydration or a sudden onset gastroenteritis, any case of sepsis, because sepsis of whatever etiology must always keep underlying possibility of a diabetic ketoacidosis. And in those cases with the starvation, because the child has not been eaten a long time and suddenly presenting in altered sensorium. So these are the things, because DKA is one of the differential diagnosis in all these conditions. Now coming to today's proper. What is diabetic ketoacidosis? It's an acute, major, life-threatening complication of diabetes. And as all of you know, it is occurs in patients with type 1 DM, very, very common. It's very unlikely in case of type 2 diabetes mellitus. It says adult onset or non-insulin dependent diabetes insulin is less common. So it is common in the insulin dependent. Now, usually precipitated by some infection or a stress or a trauma and conditions associated with increased insulin requirement. Higher the level of counter-regulated hormones, wherever there is a, because insulin suppressors, these hormones are there. So if any stress condition is there, steroids increase like that. So like that, the existing insulin becomes insufficient and it is a relative insufficiency of insulin. So these conditions you must be very, very careful. These are the pre-risk factors and predisposing factors for the diabetic ketoacidosis. Now, diabetic, what is the definition of diabetic? It is an absolute or a relative insulin deficiency resulting in hyperglycemia and accumulation of the keto acids in the blood and subsequently acidosis, metabolic acidosis. So to define DKA, diabetic ketoacidosis, usually hyperglycemia of the range of about 250 milligrams per deciliter. And since many of you may be going to USMLE, where we use only molar concentrations, 13.9 millimoles per liter. That is SA International Units, 13.9 cutoff points. You better learn both. As for the pH wise, anything pH less than 7.3, of course there are gradations are there, we will go to that later on. And a bicarb levels of less than 15 millimoles or 50 milliacres less than per liter. These are all the defining factors of the, and ketosis. Ketosis means elevated serum and urine ketosis. Serum ketones more than 5 milliequivalents, usually 2 to 3 milliequivalents, or less than it should be. So above 5 milliequivalents of ketone bodies per liter, these are the defining features suggestive of a diabetic ketoacidosis. Now, for clinically, there is severity, as I said, it is an arbitrary classification. Severity is classified can be depending on how severe is the DKA based on the bicarbonate levels, the pH, venous pH here, need not go for the ABG, and some clinical features. Welcome, Sandeep. So from now onwards, all of you will be welcome as soon as you come. So any bicarbonate less than normal is 20 to 28, okay? Less than 20 mild, less than 10 moderate, less than 5 severe. As for the serum bicarbonate level alone, or a pH, which is normally 7.35 to 7.45, all of you know. Less than 7.3 is mild, less than 7.2 is moderate, less than 7.1 is considered severe. And clinical features, the child is oriented. Welcome, Sunita. Oriented, alert, but fatigue. It's mild. The typical Kussmaul respiration, deep respirations and deep and sighing respirations, but still oriented, maybe a little sleepy, arousable. That is moderate. When the child is going for the levels of sleepy and depressed sensorium or even coma associated with the Kussmaul respirations, that you can consider as severe. So looking at the child, we can think of how deep is the ketoacidosis. And apart from this, simple severe hypernatremia, where sodium concentration more than 150 milliequivalents will also be classified as a severe ketoacidosis. We'll talk more about sodium abnormalities later on once we go there. So these are the general criteria to think of how severe, how bad is the diabetic ketoacidosis. So now, why is it happening? It's like a balancing. The ketoacidosis, how will develop? Just we have a look into the pathogenesis. So what are the normal anabolic effects of this insulin is? Use it for energy substrate and storing the glucose is a glycogen. As protein also, it is a acceleration of the protein synthesis. Welcome, Subhash. Fats are stored as triglycerides. These are anabolic effects of the insulin. What is countering them? The counter-regulatory hormones are catabolic. This is the destroying. Opposite of glucose storage is glucogenolysis. Existing glycogen is broken into glucose, where there is stress is required because glucose is produced. And instead of protein constriction by insulin, protein is destroyed by this counter. Because proteolysis and again gluconeogenesis. The glucose is formed by the protein. So these are the effects, just opposite effects of insulin. And on the fats, insulin helps in storage of fats and triglycerides, whereas lipolysis, counter-regulatory hormones, help in lipolysis. So lipids are broken into free fatty acids and ketone bodies. So these two are the opposite acting hormones. So when this balance is disturbed, what will happen? So if it is tilting on one side or other, what will happen is, so in order to produce DKA, there must be relative lack of insulin or relative overactivity of counter-regulatory hormones. That means even though insulin is normal, if there is a stress, for example, infection or any starvation or any other stress factor, so existing insulin becomes insufficient and because of the counter-regulatory hormones, and that is also led to relative deficiency of insulin. So this is how the balance may be tilted or shifted. This is how DKA develops. Now, what are all the conditions when to suspect? As I said in the previous class, DKA may be the very first manifestation of the diabetes. Kesavi, Durga. See, you people have to come earlier. All these things within 5 minutes, I am going to close them. I am going to lock it anyway. You are welcome. Latecomers, be ready for any questions. I don't know who has come later actually here. So, 20 to 40% of type 1 diabetes mellitus, you don't know this until the child comes to you with the DKA or severe dehydration or cerebral edema or even actually whatever it is, altered sensorium, shock like that. But known risk factors is inadequate insulin treatment. Suppose if you are not giving, if you remember correctly, what are the doses of insulin? If you remember, pre-pubertal 0.6 units per kg per day, whereas pubertal maybe 1 to 1.3 unit per kg per day. So at some reasons, if you are not calculated properly, you are not giving proper dosage, that can precipitate insulin inadequacy. But you have given the dose, but the patient is not taking properly. That is non-compliance. Okay, daily injection, so many injections. I just missed one injection like that. So the non-compliance is very, very common. Especially child says, I will take myself actually as a teenagers and all this. You can't rely on them. So non-compliance is one of the reasons. As I said, acute illness or infection, because not the deficiency of insulin, but the excess of counter-regulated hormones. These constitute DKA. Some of the known drugs are known to produce, like olanzapine is an antipsychotic drug. Heart, highly active antiretroviral therapy. Those people in the HIV, and some of the benign drugs like terbutaline, propranolol, some antimetabolites like elasparaginase, lithium, which is used in depression. These are all the things which may produce, and actually sometimes the addicting drugs like cocaine, especially in the adolescents, they're addicted. These are the drugs which can precipitate DKA. And the modern day, actually, if you remember correctly, last time, one of the modern latest development is an artificial pancreas. That means then a device is attached to the skin. It has a mechanism to check the glucose periodically, and depending upon the blood glucose level, it will release the insulin. There is insulin pump also attached there. So you think actually you need not, advantages, you need not have to bother about taking a medicine every time like that, remembering the medicine. But the disadvantage is if the system has means software or hardware breakage is there, you think that you are getting insulin, but if the machine doesn't give the proper dose of insulin, so the technology development problems is malfunctioning of insulin pump. So very, very dangerous, and that may precipitate ultimately into diabetic ketoacidosis. These are the predisposing factors. When to suspect these things, what if a patient comes to you, if any of these things is there or not. Now, so I look back into the basically DKA is three things. One is metabolic acidosis. The second is electrolyte disturbance. The third is osmotic diuresis. So these are the things you have to think of. Why? So when it comes to management of these things, these are the things you have to think of. Like you have to correct the metabolic acidosis, you have to correct the electrolyte disturbance, you have to correct the diuresis and counter the diuresis. So welcome, Bharadwaj. The three major pathophysiological syndromes with DKA. Quick overlook of the insulin. As I said, insulin stimulates glucogen formation into the tissue, stimulates glucose uptake by the cells. Not only glucose, actually it makes utilization, it allows the glucose to enter the cells and for the metabolic by very strong functions. Because of this, blood glucose forms. So when there is an imbalance, the same balance you have seen, the pancreas releases glucose, and these are counter-regulating mechanisms. It stimulates glucose breakdown, and also blood glucose rises, and again to balance the blood glucose levels. But this counter-regulatory becomes more or inappropriate, then the glucose abnormality, say hyperglycemia occurs, and this insulin deficiency occurs. So this is a balance between insulin and counter-regulatory hormones like glucagon, growth hormone, corticosteroids, anabolic steroids, all these things. Now, in the pathophysiology can also be explained in three cascading mechanism pathways. The first and foremost is excessive glucose production, reduced glucose utilization. So because of this, what happens? There is an osmotic diuresis. When the glucose concentration in the blood increases, it will induce osmotic diuresis because of the polyuria. With the polyuria, you will keep losing fluids and electrolytes. Leads to dehydration. Dehydration produces, when there is a blood volume has decreased, it produces our RAS system, renin, angiotensin, aldosterone axis, and it increases the potassium loss. That is the reason for the hypokalemia and the risk of cerebral edema also. The second one is increased catabolic process. In the absence of insulin, cellular losses of sodium, potassium, and phosphate. We will see how much potassium, how much sodium, how much phosphate we lost like next slide. And the third one is increased release of free fatty acids. So when there is a lipolysis occurs, the keto acids develop, free fatty acids accumulate in the body, the buffer systems are depleted, and that will lead to metabolic acidosis. So these are the three mechanisms how the absence of insulin will lead to the diabetic ketoacidosis. One is diuresis and dehydration, second is electrolyte disturbances, third is ketosis and metabolic acidosis. So this is how much actually, when there is a DKA is there, total losses from the body, nearly 10 to millicurrent, 13 millicurrent per kg of sodium is lost, 5 to 6 millicurrent of kg per potassium is lost, and 4 to 5 millicurrents of phosphate is lost. So the combined effect of serum hyperosmolarity, dehydration, acidosis, all these result in the increased osmolarity in the brain cells and clinically manifest as altered consciousness. So because ultimately because the blood-brain barrier, the changes do not occur simultaneously with the blood. So there is a increased concentration of the ions inside the brain cells, and that will attract more fluid. Ultimately, cerebral edema later on develops actually. So initially, increased concentration of inside the cells of the brain, and later on dilution effects, and that is both are dangerous actually. So look at what will happen. Usually, what will happen in acidosis, when the hydrogen ion concentration blood increases, so it replaces the cell, it goes inside the cell, and hyperkalemia develops. So acidosis produces hyperkalemia, and hyperkalemia produces acidosis. So when there is hyperkalemia, excess potassium goes inside and it releases hydrogen from the cell. So it is both ways. Acidosis produces hyperkalemia, hyperkalemia produces acidosis. These are both in hand. You can see it. Now, what is the role of insulin here? So insulin deficiency produces insulin to the individual to produce hyperkalemia. The cellular uptake, what will happen in the presence of insulin? Let us see what happens. This insulin is the key factor. Here is a cell. So let me see what will happen when I click this cell. So if there is an insulin, it will go to the receptors on the cell and literally opens a gate, and all the potassium ions in the serum, they enter the cell. So what happened? So the insulin, that's how opens up the pathway inside the cell. The assist the serum potassium enter the cell. So that is the reason actually whenever there is hyperkalemia, we give glucose and insulin like this. So that is the mechanism. Now, let us see what is the effects of the insulin on potassium level. Shift of extracellular cellularity, the lack of insulin, catabolic predominance, and it produces acidosis. And high urinary losses. Second is a compartmental shift from the serum to the inside the cell. And osmotic diuresis because of the excess glucose, and there is an osmotic diuresis. Osmotic diuresis occurs. And while the diuresis is going on, it also takes away potassium. There is a calorific effect of the hyperaldosteronism. As I said, RAS system is stimulated, calorific effect. So that's how potassium is lost from the body. Nearly 3 to 6 substantial intracellular potassium deficit. So this potassium is shifted from inside the cell into the serum because of the acidosis. So the amount is lost nearly 3 to 6 millicount per kg of potassium. Total potassium body loss. It is not a serum potassium. Serum potassium may apparently look normal, but actually body has lost total potassium, the intracellular potassium that is less. Serum levels are usually normal because of the shift from the entire cell. So sometimes very, very difficult to notice that. There is a mechanism of loss of potassium is there, but falsely, if you check the serum potassium, it appears to be normal. Shift of potassium inside the cell to the outside cell. That's why serum potassium is less reliable. You have to be very careful. Now let us see what is the effect on the sodium what is happening. So depletion secondary to urinary losses and vomiting because of the DKA also produces vomiting and gastroenteritis also. So either way, sodium is lost. Hyperlipidemia, because what is lipids, falsely produces sodium less actually. So because of the hyperlipidemia, display fictitiously lowering of sodium. So for rising, whenever the glucose is increased, the serum concentration is decreased. Actually, sodium appears to be decreased. This is a true loss. This is a false loss. Rapid decrease in serum sodium. When there is less rapidly lost in the body, there is a chances of cerebral edema because cells inside the brain are not lost at the serum. So the osmolarity inside the cell is more, which will attract water from the serum into the cells of the brain cell, neuronal cells. So the neuronal cells swell. That is how the chances of cerebral edema develops. So now how to assess the clinical features? How do you see? The symptoms are as I said, nausea and vomiting, and hydroxy, because hydroxybutyrate is a very nauseating substance actually. And polydipsia, polyuria, all of you know, because of the increased concentration. Abdominal pain, short, as I said, because the clinical presentation looks like as if it is appendicitis also. Shortness of breath because of the acidosis, small breathing. Weakness, very tired appearance, decreased tissue perfusion because the blood volume is decreased and glucose is not able to utilize it actually in the absence of insulin. And fruity breath over because of the ketotic patients, especially ketones produce a fruity breath, acidotic breath. These are the clinical features, symptoms of it. The signs, yes, there are signs of dehydration. You can see the dredging and all these things. Hypotension, you can see tachycardia, tachypnea, especially small respiration. Acidone odor, as I said, you can perceive it. Abdominal tenderness may be there. Lethargy, altered sensorium, consciousness, and possibly cerebral edema. These are the clinical features, signs and symptoms put together. Now, with this clinical picture, so other laboratory diagnosis, you may have to do some workup. In addition to that, you may have to check serum amylase, maybe because of what is precipitating. Could it be pancreatitis? Possibility. Serum creatinine, falsely elevated interference by the ketones in the autoanalyzer methodology, because whenever you see creatinine, it may not be renal failure actually. The ketones interfere with that because during ketoacidosis, interpretation of the serum creatinine is a little tricky. Please keep it in mind when you are interpreting. You don't think it is a renal failure already occurred. There is a possibility of renal failure, but you must take in view of this one. Blood urea nitrogen may be elevated. Counts that is indicate possible infection. The counts of white cell count is increased, neutrophilia, all these things possible is there. Infection precipitated. What is the etiological factor? Unless you treat the etiology, the decay is not there. CSF study, if you think of meningitis, and chest X-ray to rule out the possibility of a causes for pneumonia or whatever, what has precipitating cause, not for the DKA diagnosis per se. These are the additional workup we may have to do for the cases. Now coming to the most important thing is management. How do you manage this? Because managing DKA is a life-saving procedure in your life. For example, just like a patient comes, the surgical patient comes and you treat the surgery and you remove that problem cause, how patient becomes satisfied. Like that, this is a potential life-threatening infection condition. As a physician, if you properly diagnose and properly treat it, the recovery, the satisfaction you get when you save the child from a life-threatening event, there is immense actually. So it is very important to identify DKA and manage DKA. Therapy must address the initiating event, because what has caused it, unless you treat it, you won't be treated. So insulinopenia, that means deficiency of insulin, and subsequent physiological disturbances, like the loss of potassium, loss of sodium, all these things you must think of. So your aim is to attack all those things. So first and foremost, restore perfusion. Tissue perfusion has to be restored by volume replacement. Arrest ketogenesis. So how do you do ketogenesis? Supply the insulin. You provide insulin, the ketogenesis is stopped. Otherwise, you keep on adding more of keto acids. Restore normal acid-base balance. So if there is an acid-base disturbance, you have to be correct, either by fluid replacement or by replacement alkali. Replace electrolyte losses. If the sodium is lost, sodium has to be replaced. Potassium is lost, potassium is replaced. Phosphate is lost, phosphate has to be replaced. And how you replace will cover it. And intervene if complications occur. There is a possibility of cerebral edema, such thing, complications are there. So you must identify early and treat them. These are the major aims of your management. Next, these are the 10 about 12 steps are there. Remember these steps. First, confirmation diagnosis. Just, you cannot suspect it. You must manifestation lies the plasma glucose, positive for serum ketones, and you must manifest the venous pH, as I said, 7.2 or 7.3 or 7.1, all these things you have to. So the confirmation of the diagnosis is most important. And when we admit in intensive care patient, and monitoring is continuously, especially when the child is unconscious, and assessment of the serum electrolytes like sodium, potassium, bicarbonate, magnesium, chloride, all whatever possibilities, acid bed status, pH, bicarbonate, PCO2, and bitrate, beta hydroxybitrate. Renal functions have to be assessed by the creatinine and urine output. And next, replacement of the fluid. First hour, how do you replace? The remaining 24 hours. This is actually calculation. We will go to the next slide actually. So you have to plan in a proper replacement. Fluid replacement is the most basic thing in the management of DKA. Next is insulin action. So administration of the assessing of the start acting insulin will go into that, how much insulin, how you give all these things. And constant monitoring, assessment of the patient. So what basically this, after attending all these things, then you can think of what are the possible causes, how it has started, how it, this may take a little less priority until you have to attend these things first. Then you think of what is the possible etiology, then you go for the cultures, X-ray, CCG, all these things you can take a little later time. Then measure the capillary group, keep on monitoring. Actually, once you start giving medicines, and actually it's not sufficient whether you have whether the medicines are taking effect or not. Monitor blood pressure, the vitals, vital input output light, all these things are important. Potassium replacement is very, very important. Now at this stage you can think of potassium replacement. Initially no hurry. Bicarbonate and phosphate, even less priority actually, later on only. Continue monitoring of the patient is stable or glucose level into 150 to 200. But insulin infusion may be decreased at this stage, and at this stage, think of stopping insulin infusion and think of moving long. That is it, parent to the subcutaneous insulin dosages when the patient is eating. So these are the 12 steps actually. It should be 12 actually. Okay. Now this is the management of the insulin therapy, of fluid therapy. The protocol I am suggesting is a modified Milwaukee DKA protocol, a little different from the what is given in United States. So we'll see this actually. This following this is very, very important. This slide is extremely important. Take a screenshot, or actually when you are taken the PDF also, just put it in the examination, put it in the tabular form always. First hour, you replace with the isotonic crystalloid 0.9% sodium chloride or rigorous lactate, 10 to 12 ml per kg. So this is like any shock therapy. Quickly you have to give 20 to 30 minutes, and if pulse has not perceptible, or if the child is in shock, you may have to repeat again another bolus, like the maximum 3 boluses. At this stage, nil orally. You don't give anything orally. Monitor input output and neurological status, whether the child is conscious, coherent, is worsening, improving, like that. All these things you have to do is the first. Second hour, once you have completed the volume replacement actually in the first hour, then you reduce the concentration of the sodium to half normal saline, 0.45 sodium chloride in normal, in water only, not dextrose, because it is half normal saline only, not dextrose saline. Please remember that. Then you start thinking of adding up plain insulin. The dosage is 0.05 to 0.1 unit per kg. Here normal daily requirement of diabetes management is 1 unit per kg. Here it is 0.1 or 0.05 to 0.1 unit per kg per hour. So that you have to start it preferably a different drip, separate line, and dilute the normal saline, and you run the separate drip, because minimum 2 lines are necessary always in this stage. You cannot mix up with the fluid replacement, has to go fast. This has to go slow because we cannot increase the volume. And you can add phosphates and potassium 20 milligrams later, second hour, depending. I will talk about potassium later on more. And if the blood glucose falls below 250, then think of adding 5% dextrose. Only if the blood glucose falls below 250. Please remember that if it falls below 50, you have to add 5% dextrose. Otherwise, the patient is going to hypoglycemia, opposite side of it. That is also dangerous. So always keep monitoring. So these are the steps you do in the second hour. So from second hour onwards, up to remaining 23 hours, you calculate the fluid like this. So 80 ml, 85 ml per kg of fluid, whatever fluid, it is half normal saline or 5% dextrose, with or without dextrose, whatever it is, plus maintenance fluid. How do you calculate maintenance fluid? Holiday agar. You remember holiday agar? The below 100 ml kg, 10 ml per kg. After that, 50 ml per kg by about 10 until 20, about 20 ml per kg per each kg, about 20. So these are the holiday agar formulas, maintenance. And above, from this, you will subtract the bolus. Already you have given something in the 10 to 10, 20 ml in the initial one. You remove that one. And this volume, you divide by 23 hours, because already 1 hour is over. So like that, this has to be given in the infusion pump. So the calculation of this 85 ml per kg plus maintenance minus bolus divided by 23 hours. Now potassium, should we give or not? Below 3 milliequivalents, if it falls, the serum levels, then give potassium 0.5 to 1 milliequivalents. Preferably orally if the patient is conscious and coherent, and IV maximum amount you can give is 80 milliequivalent per liter. The concentration when you dilute, you always dilute. You cannot give as a bolus. Potassium has to be given potassium chloride mixed with the fluid only. Either you have to give in the separate pump or actually in the fluids only. You calculate in the concentration that way and mix up. And once oral intake is there, subcutaneous insulin is started. We'll come to that. Provided no emesis, and bicarbonate is more than 16 milliequivalent or normal electrolytes are there, you can think of changing. So this is a general sketch of how to give fluids and insulin in case of DKA. Just follow that. So initially, this is in a nutshell, this is a flow chart. Initially, isotonic fluid 0.9 normal saline, 1 to 2 liters or 1 to 2 liters is adults actually. So you will calculate according to the 10 to 20 ml per kg. Till the plasma volume is replaced. How do you know plasma volume is replaced? Pulses regaining or child passing urine. So after that, you change it to half normal saline, and if the blood glucose falls below 300, add dextrose, either 5% dextrose, or if the blood glucose falls very low, you may use 10% dextrose. So this is the adult manifestation when this I have taken. So this is a nutshell actually in examination. Even if you put this table also, very explanatory. Always go for the table and flow charts in the exams. Please remember that. So now we'll talk about the electrolytes. Most important is potassium replacement. Remember, total potassium may be deficit, but presentation serum potassium may be normal or even sometimes high also, because the potassium is replaced from the cells into the serum. That's why be careful in interpreting the serum potassium. So potassium should never be given until serum potassium levels are obtained. You get the laboratory just thinking that DKA produces hypokalemia, so I have to give. Do not believe that direction. And acidosis must, correction of acidosis is must, because acidosis correction, once you correct, what will happen? The potassium goes back into the cells energy. So after that only you know what exactly is happening in the serum. So once you correct acidosis, the potassium may go back into the cells, then you will get a correct picture of the serum potassium. So that's it. And whenever you think of potassium replaced, because of the correction of acidosis, whatever potassium are given also may disappear into the cells. So don't be complacent, keep on checking the potassium. 20 to 40 milliequivalents as potassium fluoride or potassium phosphate added IV fluids. Once urine is established, how do you know it? You can give potassium until the urine output is not there. Never give potassium. Please remember that. Never administer intravenous potassium unless you have documented the child has passed urine. So renal shutdown is there means very dangerous. You may be precipitating death by cardiac arrest by giving potassium. Serum potassium is less than 5. So these are ECG findings. You can see the U waves in the serum potassium. So how much potassium? This calculation is there. The serum potassium is less than 5.5. Usually no replacement is necessary. If it is more than 5.5. Between 4 and 5, you may have to give 20 milliequivalents per liter of the replacement fluid for each liter. So that's why adding 20 milliequivalents of potassium. If the serum potassium is 3 to 4, you may have to use 40 milliequivalents. Never increase the 40 milliequivalents per liter concentration at all. This is the maximum limit concentration you can give in intravenous drips. So this is a. Or sometimes if you are administering soda bicarbonate, then usually we don't give soda bicarbonate. But please remember, if at all you are giving soda bicarbonate in the management of metabolic acidosis, very few conditions, I will talk to that later. In such cases also, because soda bicarbonate may counteract the potassium effect, you may have to think of administering potassium, even though the potassium levels are a little more than 3 to 3 or 4. So these are the conditions where you give potassium replacement. Okay. Now coming to the sodium replacement. So initial sodium is usually normal or low because of the osmolar dilution or hyperglycemia and the effect of elevated sodium free lipid fraction. Because of the hyperlipids, actually all these things fictitiously serum sodium levels may come up. True serum sodium at any given glucose above 100 milligrams per deciliter, whenever the glucose concentration is more than 100 milligrams, this is the correction factor you do. Sodium, observed sodium plus 1.6 milliequivalents per liter of sodium for every 100 milligrams of deciliter of glucose, excess of 100. Suppose if it is 150, blood glucose is 150, That means you have to go 0.8 milliequivalents. This is half of 1.6. So if it is less than is 300, that means you have to give 3.2 milliequivalents of sodium. You have to add for the what you have observed. So that is a fictitiously reduced. That's why this is how you calculate the actual and compute the actual serum sodium. So if the corrected value is more than 150 millimoles or milliequivalents, serum hypernatremia, it is called as severe hypernatremic dehydration, and may present and may require the fluid replacement. Whenever there is hypernatremia, remember, do not correct it rapidly. What will happen? Cerebral edema. You are therapeutically inducing cerebral edema because the brain cells take a little time to adjust it. Actually, if you rapidly correct it, the fluid goes very rapidly into the cells and produces edema of the brain cells. So that's why never replace serum hypernatremia very rapidly. Decline in sodium may indicate excessive free water in the water accumulation, increase the risk of edema. So that is also dangerous. Suddenly you don't reduce the blood, serum sodium levels. Treatment of DKA. Once dehydration of the fluids and potassium are running, blood glucose level will also start falling. Please remember that. So sometimes your just fluid replacement itself can reduce the potassium. So when you are giving insulin, start intravenous insulin infusion 1 to 2 hours after beginning, because even the Nelson textbook of pediatrics shows in the first hour itself insulin. But Milwaukee regime and most of the British regimes now, they advise not to give insulin in the first hour of management. So in pediatrics, it is always safe to start insulin in the second hour, not in the first hour. Do not give bolus doses insulin because there is no role for the bolus doses at all. It is only starting insulin rate. Insulin, low insulin infusion, even less than 0.0 to 0.05 also are usually sufficient in some cases children, especially small children. So maximum you go is 0.1 unit. What they say is pediatrics, you better start with a smaller insulin levels because your fluid replacement itself will correct some of the problems. So these are the precautions when you are giving insulin that you must observe. So when to stop insulin drip? So insulin, you have started, blood glucose falling, acidosis is one corrected, and clinically pH becomes normal, is an indication to stop drip. Negative ketonuria has decreased because ketone negatives, urine has come negatives, and child is eating and looks good and feels good. The general appearance. So these are the 3 criteria based on that. Okay, now we can stop insulin drip. You have started insulin drip is easier. When to stop? These are the criteria to think of stopping insulin. After stopping insulin, what will you do? You'll give subcutaneous insulin. So now a word about bicarbonate, very, very important. Usually metabolic acidosis means you think you're giving bicarbonate, but no. Bicarbonate should not be used routinely in metabolic acidosis, because it's very dangerous. It is converted into carbon dioxide in the body and may increase acidosis sometimes. That's why the only indication is the pH does not improve in spite of your previous fluid replacement, insulin replacement, all these things. Arterial pH remains very much low, that is less than 7, venous pH less than 6.9. So these are the indications we may have to go for a direct blunt administration soda bicarbonate. Or sodium bicarbonate levels less than 5, very, very dangerous. In such cases, so discontinue. Once the pH is come back to 7.1, immediately stop administering soda bicarbonate. Or the soda bicarbonate comes about 10, whatever infusion you are giving, you must stop. Be careful not to give. These are the only indications go for the soda bicarbonate. Whenever you give soda bicarbonate, you have to give potassium dose also increase. That is the precautions. Just remember. Now, just administering drugs is not sufficient. Fluid balance. Always keep a check on how much fluid is going in, how much urine is coming out, because you should not produce excess hypervolemia, because therapeutic cerebral edema is dangerous. Most of the problems is iatrogenic. Sometimes out of your over enthusiasm, you may have to try to replace. Child is dehydrated, look, actually let's give a little more fluid. Dangerous, very dangerous. So venous pH and serum bicarbonate, serum ketones keep on checking every 2 hourly initially, and later acidosis and severe bicarbonate is given. Hourly pH is also important if you are doing administration of bicarbonate. Blood sugar every hourly, and serum electrolytes every 2 hours, and if it is stable, then every 4 hours. So these are the minimal medications, and of course you have to maintain the chart of the temperature, vitals, all the BP and blood pressure, pulse rate, heart rate, temperature, all these things. In addition to that, these are the additional monitorings. What complication can occur? As I said, dehydration itself is a 1%. Hypotension, even leading to shock, is one. Metabolic acidosis, non-anion gap hyperchloremic metabolic acidosis also can develop with this. Hypokalemia or hyperkalemia, because depending upon how much you administer actually. So acidosis produces hyperkalemia, and your treatment also produces hypokalemia. Total body loss is hypokalemia. So both are possibilities. Hypoglycemia, that is the essential feature actually. Sometimes aspiration pneumonia can occur. Sepsis may be the cause or even effect of the DKA. Acute tubular necrosis may lead to acute renal failure also. Stroke can occur because of the decreased perfusion and actually hypohemoconcentrations. And the most important, dreaded cerebral edema. So these are the complications we may face of the diabetes. So speaking of cerebral edema, so 1% of the childhood DKA and associated with the high mortality and neurological mortality. There is so much common in this. It is attributed to cellular swelling as a result of rapid osmolar changes occurring during IV infusions. Because, as I said, the brain cells, because of the peadiatric osmoles are developed inside the cells, and they try to preserve the concentration of the osmolality inside the cell. And when you replace the fluid, and it may take up, because that is inside of the cell is considered as hypertonic, it will absorb water more very rapidly and lead to cerebral edema. So rapid corrections are very dangerous. Parent presents gradual deterioration. How does you see it? Maybe the gradual deterioration or worsening of the conscious level. When the child came, is already responding stupor state, and gone to the coma stage later on. Or gradual improvement. There is an improvement and suddenly worsen. So either way, it can present actually. Suddenly, you face child is improving, you think, and child has become very bad. So these are the possibilities of cerebral edema. And clinically, you can see that actually the MRI shows the uniformity. The gray matter and white matter disparities disappeared. Actually, cerebral edema, swelling of the cells, and they're actually tenting this Fox cerebral, bending of the cells. Clinically, there is major and minor criteria I mentioned. As I said, apart from the neurological alters mentation, fluctuating level of consciousness, sustained and inappropriate bradycardia, age inappropriate incontinence. Because child is previously toilet trained, now he's not telling it all. So these are the major criteria. Minor criteria: vomiting, headache, and abnormal drowsiness, and diastolic hypertension more than 90. So these are the general criteria for the cerebral edema. So if at all, how do you manage cerebral edema? How do you manage? Now, at this stage, I'll give a chance to my latecomers. So, who will answer? Monica, would you like to say? Are you there? Hi, guys. What happened to people? Are you listening?
Yes, sir.
Tell me one method. How do you treat cerebral edema? Just one idea. These are only just ideas only. So first and foremost, what is most important in that? The recognition is most important. Then only you can treat it. So first and foremost is urgent recognition. So you have to, when you are monitoring the child. So what are the methods to reduce cerebral edema? Any idea? Mannitol, 20% mannitol,
Diabetic.
0.5 to 1 gram per kg infused over 30 minutes, which can be repeated after 1 hour. So apart from mannitol, now recently, what has changed? Replace mannitol? Hypertonic saline, 3% hypertonic saline, 5 to 10 ml per kg infused over 30 minutes, which can be repeated after 1 hour. So mannitol and 3% saline are most basic things you may think of in treatment of the cerebral edema. Now elevation of the head end is about 45 degrees, very, very important thing, all those cases cerebral edema. Reduce the IV fluid rate. If you are giving previously whatever the rate is, reduced by 70% of the maintenance. Usually calculate according to Halliday's agar and reduce to 3/4 of it actually. If you calculate about 100 ml per kg, you have to give, now give only 70 ml per kg only. That is a hypovolemic treatment actually. Consider intubation and controlled hyperventilation. Hyperventilation, it produces, reduces vasoconstrictive effect of hypercapnia. So hypoventilation, hyperventilation. So reduce the when the photon, this carbon dioxide effect, you counteract the carbon dioxide effect. And oral glycerol are the things if the patient is conscious and other things actually. Now, therapeutic hypothermia usually used in case of traumatic brain injuries, not in the DKA. And there are other things like barbiturate coma are also mentioned. These are all the methods we think of cerebral edema management. But most important thing is mannitol and the deep saline and hyperventilation and positioning. These are the most important manifestations. So, to summarize, diabetic ketoacidosis is a common, serious, expensive complication in patients with diabetes. Prevention of the metabolic decompensation through patient education, strict surveillance, and glucose homeostasis and aggressive diabetic management might reduce the high morbidity and mortality associated with diabetic ketoacidosis. So that is about the system. Okay, that's the end of the diabetic ketoacidosis. Now, guys, if those of you who have been listening, any questions now? Subhash, you have come very, very late. What time you came? Sorry, one of the first person to come, I think, Subhash. I will ask Aparna Sai or Ajay. Ajay, where are you? Are you there? Hello?
Sir.